Hi everybody, welcome back to the Canadian Rheumatology Association and Arthritis Health Professionals Association annual meeting. We have for this session Dr. Gilles Boire, professor in Division of Rheumatology and Faculty of Medicine at University of Sherbrooke. And you're busy at this meeting this year.
Yeah, I participate to a panel on chronic or refractory monoarthritis, and we have a few posters too.
Okay. Can you explain to our patients out there what type of arthritis this is? The monoarthritis, the refractory monoarthritis, what that is?
Mono means only one. So it's a disease where only one joint is involved. And refractory means that it's not something that tends to resolve by itself. And it's sometimes very difficult to get under control. In fact, it's a number of different diseases. In some cases, the disease will persist as a monoarthritis without any signs, or in other cases it will evolve to more diffuse arthritis like rheumatoid arthritis or psoriatic arthritis or spondyloarthropathy. But it's only a minority of those cases.
Okay.
In some cases, the disease will just disappear by itself.
After remission by itself?
Yeah, by itself or after a joint injection, for example.
Right.
But we have to rule out other diseases such as infectious disease, sometimes tumor. Some are benign, but others very rarely may be cancer lesions. So it needs to have a very structured approach to
it seems like it's more investigation than the standard things that we're used to being tested for or looked into for something like this, because it could be so many different things that you would have to investigate deeply.
And in some cases, if we don't do the right diagnosis, the disease may get worse because of treatment. For example, if we treat it as an autoimmune disease, but in fact it's an infectious disease, then the infection may spread or cause more damage to the
because
joint.
you're suppressing the immune system.
Yeah.
That must be a challenge for the patients as well.
It's always a problem because it seems sometimes it seems such a simple thing. It's only one joint. Why can't you rule it? Just heal it. But sometimes we talk about the refractory ones, so the ones that don't get under control easily.
Do you think that is the time to diagnosis longer because a lot of patients will not seek treatment for it because it's one joint that's hurting and they're perhaps writing it off to old age, or that it's something else, or maybe I strained it, or all the reasons to not go to the doctor?
Yeah, that's because sometimes when it's only one joint, you may have non-inflammatory causes like osteoarthritis, for example, or a sprain or trauma, and so yeah, that's right. People get more time to get, because very frequently those monoarthritis problems are related to gout, for example, or so they tend to resolve by themselves and just to recur years or months later.
So don't underestimate the pain in just one joint.
Yeah,
is key.
Especially if there's inflammatory signs with swelling and warmth
well, that's a good practical information for patients to not ignore your pain.
Yeah.
Correct. So let's move on to your posters. You have several posters at the meeting.
Yeah.
If you could tell us what you're presenting.
Well, I'll discuss maybe two of them.
Okay.
One is an interesting aspect because we frequently find that we treat the disease in rheumatoid arthritis, and the patients appear to be responding well. The joints are not swollen anymore. There's no more inflammatory signs, either clinically or in the blood. But some people continue to have the impression that the disease is very active or has a big impact on their quality of life. And as rheumatologists, it's something that is difficult to manage because we don't have the tools for that. So we considered having a pilot trial of an approach that's called mindfulness-based stress reduction. It's a group. There are group meetings where there's a teacher that helps patients to just take some distance from what they live. So just live in the present moment, meditate, inspire, just the respiration, and it gives them breathing.
Yeah, breathing.
Sorry.
So we talked about that yesterday with a yoga therapist.
Yeah. So these are tools to really give some control to the patient on the disease process, because the disease we don't need to add more anti-rheumatic drugs or things like that. It won't help.
Well, most patients don't want to take more drugs.
Yeah, and they don't need to.
Yeah.
And so what we did, we had four groups of about 10 patients each, and we measured a number of variables such as stress or anxiety, depression, fatigue, sleep quality, quality of life before and 6 months after the end, because the intervention of mindfulness-based stress reduction is 10 weeks long. So we measured 6 months later, and what we observed is that there's a marked improvement in, we did both quantitative, that means measuring the degree of anxiety and depression, and these decrease markedly. And we asked also qualitative data, what they felt that had changed for them. And that's very interesting that the patients feel that they have a better control, not only on the disease, but on other stressful situations.
Well, yes, because we know stress can induce a flare, or it doesn't help us.
Yeah.
And do you think that there's a possibility down the road at looking at, I was just, off the top of my head and thinking while you were saying that, including this type of practice from diagnosis to assist in the treatment process, because there is a lot of stress when someone is newly diagnosed, and fear and anxiety, and then the depression comes, there's grieving, there's lots of factors.
I think it might be a good idea, but we didn't use that approach because when at first when the disease is active, we need to control the disease, because just giving stress reduction tools won't help for the disease.
No, not simply that, but along with.
I think it might be a good idea, but our aim at this point was to measure whether that intervention would improve.
Correct.
And what it would improve. And the other aspect was, would it be something that was felt to be interesting for the patients? And what we found is, for some patients, yes. For others, it's
like everything.
It's a lot of investment. You have to go 2-3 hours each week, and for 6 weeks, then have a 1-day retreat, and again 2 weeks of weekly meetings. And for many people, it's difficult just to have the travel or to take the time and to do the exercise in between. So some people can invest in that, doing that, and they usually tell us that they feel that it's a tool that they continue to use after that. And I have personally have a few of those patients that are my patients, and I can see that they in situations at work or not only related, it's a generic tool to help really manage when you have a stressful situation, and they feel it's something that they want to continue to do over time. At this point, I think it might be something that might be very interesting. It's difficult to do it for everybody, but when the disease is not active that anymore, I think it's a good time to do.
Well, absolutely, for measuring, for your purposes, for being able to measure outcomes. But I think, do you think in general that these are good practices for people to implement even one at a time themselves, whether it's breathing, whether it's meditation or relaxation of some type, that's easier to implement, that they don't have to, if they can't commit that time or they're in a remoter community, or just to find something that they can obtain those tools?
Yeah, there are currently attempts to do that on the internet, for example. We didn't do that. We did something with where the teacher was in the presence of the group, but it might be an alternative for that situation.
Yeah.
But I again stress that when you're in an acute situation, it's probably very
It's more
difficult.
challenging when it's acute.
Yeah, it's better to really improve the acuteness of the situation than give tools.
And and your other posters that you're doing?
Yeah, one of the other poster we have is that it's a post-fracture intervention. That means people have a fracture, what we call a fragility fracture. That is a sign of osteoporosis, of bone fragility. And then we assess what if it would be a good idea to give not only treatment, drug treatment for that, but also to refer to a fall prevention program, because we in our province there are in many cities fall prevention program, but it's not necessarily the right people that go to those, because when you had a fracture you have already identified yourself as someone who can have a new fracture. And it's what we report. We did a comparative outcome study in the patients who had the intervention and other people with fragility fracture from other comparable cities in Quebec, and see what happened with them. And what we found is that the people who have the intervention, they are more active physically. They tend to fall less, which is a good idea.
I think that, for a lot of us who don't have those tools, the fear of having a fall or getting a fracture and what that's going to do to you from that point forward, or how it's going to, the process of going through that is very frightening. And so,
you're right.
But a lot of people don't look to fall prevention until it's too late. It's recovering from a fall they've already had.
And most of the fractures occur after a fall. And if we can help people not only to have stronger bones, but to fall less frequently, or at least when they fall, to try to have a better way to fall.
How to fall. Like when you're skiing or snowboarding.
Exactly.
How to fall properly. Well, thank you so much. We're going to refer to Anita, our producer, as if there's any questions from the audience.
This is a question emailed to us. Do you think diet and lifestyle changes, such as more exercise or practicing mindfulness, can slow disease activity or put it in remission?
I don't think so. I think it's a at least for mindfulness-based stress reduction. In our patient, it did not change the measures of disease activity. But it's not that but I cannot answer for the healthy diet or, well, I recommend healthy diet. I recommend not to smoke. I recommend not to drink too much. But will it be enough to bring the disease that is active under control? I don't think so. I think it's something that can help or improve the odds of having a good response, but it's not by itself a sufficient treatment.
Yeah, because I don't think that those, the research isn't there yet on all of those things together or parts of those things, but it's always a good idea to practice those things.
Yeah.
As a complement to
Exactly.
what you're doing with your rheumatologist or your caregivers. Well, thank you so much. I hope we covered everything that we could or highlight to help all the patients that are watching us,
Okay.
and to the important work that you're doing. So thank you for taking the time to come in and see us.
It was a pleasure.
Thank you.
Thank you.